The main neurostomatological syndromes: neuralgia of sphenopalatinem, otic, ciliary ganglions and angiotrophoneurosis. Facial pain can be developed due to the next processes: trigeminal neuralgia and, rarely, glossopharyngeal neuralgia. Facial forms of migraine, including cluster vascular pain, Charlin and Slater sympathalgia, psychogenic head pains, cranial neuralgia and central reasons of pain. Trigeminal neuralgia, characterized by short, intense lancinating pain, often occurring at frequent intervals and confined to one or more zones of trigeminal nerve. Trigeminal neuralgia, polyetiological disease, arising at mainly, more than in 90% cases, at the age more than 40 years. 60 to 70% of patients are women. The most frequent reasons: mechanical compression of nerve, formation of sclerotic plate, infections in an oral cavity, vascular malformations or tumors, basic lesions of the brainstem. Clinical features. The second branch of trigeminal nerve is involved in pathological process in 44% cases, third, in 36%, first, in 20% cases. The repeated attacks usually rise up in the same zones of face. Emotional and physical trauma can increase frequency of attacks. Through some time, dull pain or feeling of burning appears in patients in an inter-attack period. Paresthesia with hypoesthesia can appear only after injection-destructive treatment, signs of neuropathy. Autonomic supplement of pain attack is observed in less than 1/3 of all patients. Resistant autonomic disorders, changes color of skin, desquamation, hypertrophy of soft tissue, can be only in patients which had injection-destructive treatment. Clinical manifestations, symptoms. Usually unilateral. Only 4% of patients complain on bilateral paroxysms. The right side of the face is more often affected. The third segment is more often affected than the second, which, in turn, is more often affected than the first. Brief paroxysms of intense, lancinating pain, seldom lasting longer than 1 minute, are often triggered by cold, eating, speaking or touching the face, trigger zones. Typically, remission of pain occurs, lasting months or even years. Eventually, the pain becomes chronic. Course: disease has typical remittent course. Many patients describe that attacks do not disturb months and years. Disease course includes exacerbation and remission. In the period of exacerbation, patients answer on questions monosyllabically, barely opening slightly a mouth. The least motion of facial muscles can cause pain attack. During attacks, patients stop beating. The diagnosis of trigeminal neuralgia is based on characteristic signs: paroxysm of pain in area of face or forehead, lasting from a few seconds to 2 minutes. Localization of pain in area of one or a few branches of trigeminal nerve. Brief paroxysms of intense, lancinating pain, seldom lasting longer than a minute and absence of it in an inter-attack period. Suggestion of pain from trigger zones: cold, eating, talk, washing, cleaning of teeth, speaking or touching the face. Stereotyped attacks for the same patient. Distribution of trigger zones. Thus, on the basis of information about somatic and neurological examination, other reasons of head and facial pain, local processes in nasal sinuses, teeth, jaws, pharynx or basis of skull should be eliminated. Glossopharyngeal neuralgia. Definition: glossopharyngeal neuralgia is the occurrence of spasms of pain in the sensory distribution of the 9th and 10th cranial nerves. Etiology and pathology. the cause is unknown, can be due to the pressured on or entrapment of the ninth TH and XTHCN. Glossopharyngeal neuralgia usually occurs after acute infection of the pharynx. It can be associated with compression in different sites: the cerebellopontine angle, jugular foramen, base of the skull, pharynx, and tonsils. Glossopharyngeal neuralgia clinical features. Rare condition. Typical short spasm paroxysm of pain in the pharynx or the base of the tongue, tonsils. Attacks are usually brief but may last for several minutes in severe cases. Attacks are occasionally associated with bradycardia, cardiac arrhythmias, falling BP or hypertension, and syncope due to associated vagal stimulation, caused tumor of pharynx. Typically triggered by swallowing, especially cold solution, coughing, chewing, talking, yawning, sneezing, turning the head to one side. Glossopharyngeal neuralgia clinical features. Triggers zones, touch to the soft palate or tonsils, sometimes by touching the tragus of the ear. The neurological status is normal, disorders of sensitiveness or paresis are absent. Often there is spontaneous remission from a few months to a few years. Hypersecretion of the parotid gland has been reported. Combination with the trigeminal neuralgia is possible, compression of both nerve by complete arched vessel. Sometimes pain irradiated to ear and neck, or only into the ear, oticalgic form. Diagnostic procedures. A diligent search should be made for a compressive lesion in the area of the cerebellopontine angle or at the base of the skull using magnetic resonance imaging, MRI, or CT scanning, which provides clear views of the jugular foramen. Differential diagnosis. Sometimes a similar pain syndrome is marked at the tumor of pharynx, including nasopharynx, tongue, posterior cranial fossa. Tonsillitis, paratonsillar abscess. Hypertrophy of processus styloideus. In last case pain increases at the turn of head. Neurinoma of glossopharyngeal nerve is observed exceptionally rarely. Asymptomatic neuralgia should be differentiated in young people with permanent pains and symptoms of neurological deficit. Treatment are same, as well as at trigeminal neuralgia. Treatment: carbamazepine, Tegretol, as described under trigeminal neuralgia. Intracranial sectioning of the glossopharyngeal nerve has been performed in intractable cases. This procedure entails a section of the upper two rootlets of the vagus nerve and may be associated with postoperative hypotension and cardiac arrhythmias. Superiolaryngeal neuralgia. Typical paroxysmal one-sided or bilateral episodic lancinating pains in larynx, usually at the level of upper part of hypothyroid membrane, an angle of mandible. Irradiation in eye, ears, thorax and forearm. Pain is associated with hiccup, hypersalivation, cough. Pain is provoked by swallowing, yawning, cough, blowing, motion of head. Some superiolaryngeal neuralgias are caused malformations of neck. Carbamazepine, finlepsin, and local anesthesia in hypothyroid membrane are effective. Geniculate neuralgia. Definition: geniculate neuralgia is episodes of severe lancinating pain occurring in the region of the pinna and external auditory canal. Etiology and pathology. The etiology of this condition is unknown. Neuralgia affecting the nervus intermedius, the bipolar neurons of the intermedius are located in the geniculate ganglion and the afferent axons enter the spinal tract of the trigeminal nerve. The peripheral fibers are distributed to the external auditory canal and the pinna. There may also be some distribution to deeper structures of the face and hard palate. Clinical features. Typical spasmodic attacks of severe pain in the region of the pinna and external auditory canal. The pain is occasionally felt in the throat, deep in the face and in the orbit. Treatment same as for trigeminal neuralgia. Surgical excision of the geniculate ganglion has been performed in some cases. Facial sympathalgias is the group of the similar clinical states. As a rule they have paroxysmal courses and normal state between attacks. Attacks last from 10 minutes to days, rarely. Typical sign is the acute, often unendurable pain in face, sometimes pulsating character. The important clinical sign are autonomic signs on the side of pain. Lacrimation. Conjunctival injection. Rhinorrhea from one half of nose and nasal obstruction. Forehead and facial sweating. Syndrome meets more frequent among men. Attacks happen acutely, mainly at nights. The sharpest pain does make a patient to move, because at rest pain becomes yet sharper. Facial sympathalgias are expression to on-principle different forms of pathology. Sympathalgic syndromes, lesion of autonomic peripheral ganglions and nerves. Nasal ciliary neuralgia, Charlon syndrome. Pterygopalatal neuralgia, Sluder syndrome. Neuralgia of large petrosal superficial nerve, Gartner syndrome. Vascular syndromes, as migraine. Cluster headache. Cluster effect, Horton histamine migraine, Garis migrainous neuralgia. Glaser carotid syndrome. Sympathalgic syndromes, cause the lesion of autonomic peripheral ganglions and nerves. Pathogenesis. Sympathalgic syndromes, Charlon and Sluder, are caused by pathological process of peripheral autonomic ganglions or their irritation. The etiology is not enough clear. Herpetic rashes in case of Charlon syndrome tells about herpetic ganglionitis of nasal ciliary ganglion. Etiology of pterygopalatine sympathalgia is nasal sinus infection, in particular, in maxilla cavity, and lesion of ganglion pterygopalatine. Charlon syndrome, ciliary neuralgia. Typical attack of one-sided pain in internal corner of eye and base of the nose, in an eyeball. Irradiation in a nose. Rhinorrhea and nasal obstruction. Conjunctival injection, blepharospasm. Pain is typical in internal corner of eye. Usually an attack is associated with acute lacrimation, changes in the front part of eyeball, cornea, phenomena of keratitis or iritis. Herpetic exanthema at skin of the nose. The Charlon syndrome should be differentiated with herpetic ganglionitis of trigeminal ganglion. It manifests as symptoms in zone of one branch of trigeminal nerve innervation. Bright autonomic supplement is not typical. Sluder syndrome, neuralgia of ganglion pterygopalatal. Pain is localized in base of the nose, maxilla, teeth, tongue, soft palate, ear, neck, shoulder area. Then with irradiation in an eye and temple. Sometimes there is reduction of muscles of soft palate, typical click. The attack of pains begins and finishes gradually. Course of attack protracted. Certain periodicity absence. Pain of middle cruelty without motor anxiety. After an attack, paresthesias in face and noise in ear. Differential diagnosis. Typical signs of neuralgia. One-sided autonomic features. One-sided edema of face in the attack period. Differential diseases. Chronic angiotrophoneurotic edema. Typical localization in lips, cheeks. Bilateral edema does not cause diagnostic difficulties. Local edema of orbit. Edema yet and pain syndrome. Angiotrophic edema in channel of facial nerve conduce to insufficiency of facial nerve. Recurrence of facial neuropathy in combination with a plicate tongue. Halitis is determined as disease of Rosolimo-Melkeson-Rosenthal. TREATMENT. Application of autonomic tropic drugs, ganglia blockers, viroxanum, an innervation effect on the ganglion. Antiepileptic drugs, carbamazepine, Tegretol, finlepsin. Psychotropic medications, tranquilizers and antidepressants. Effectively in acute period greasing a cocaine or lidocaine of middle nasal cavity. novocaine or lidocaine blockade of autonomic ganglions, vascular syndromes. Vascular syndromes are more frequent in patients with so-called facial sympathalgias. They manifest as attacks described before, are more typical for men. Cluster syndrome, Horton histamine migraine, harass migrainous uralgia. Term cluster headache, CH, is most correct, as reflects the characteristic features of disease and shuts out mixing of them with a migraine. Etiology: the etiology is unknown. In basis of disease is a paroxysmal dilatation of branches of carotids, deficit of sympathetic innervation of vessels with the increase, rarer decrease, of local cerebral blood circulation. Epidemiology: the condition is considerably less common than migraine, perhaps 50 times less, although not so in the author's own outpatient series. Approximately 80% of patients are male. A family history of the condition occurs in about 2% of cases. Mean age of onset is in the late 20s, 20 to 40. Rarely, comparable cases have evolved in association with a structural brain lesion, often located around the cavernous sinus. Symptoms of cluster headache: unilateral pain, although it may transfer sides in subsequent attacks. It is orbital or periorbital but occasionally radiates ipsilaterally to the forehead, jaw or neck. Continuous, characteristically intense. Attacks last from 15 to 180 minutes and usually occur once or twice a day. Alcohol can trigger the pain. Nausea may occur but vomiting is rare. The paroxysms typically occur at the same time of the day or night. The pain is not usually pulsation but more continuous. Autonomic manifestations. They include the following: lacrimation, conjunctival injection, rhinorrhea or nasal obstruction, altered forehead sweating, Homer's syndrome, Horner's syndrome during an attack of cluster headache. Clinical course: typically, bouts of pain last for a few weeks, then remit but return at intervals thereafter. Chronic cluster headache is defined as a headache phase persisting beyond 12 months. Criteria for diagnosing cluster headache: at least 5 attacks fulfilling the following criteria. 1. Severe unilateral orbital, supraorbital and / short temporal pain lasting 15 to 180 minutes untreated. 2. Headache is associated with at least one of the following signs ipsilateral to the headache: conjunctival injection, lacrimation, nasal congestion and rhinorrhea, forehead and facial sweating, miosis, ptosis, eyelid edema. 3. Frequency from every other day to 8 each day. Cluster headache. Cluster headache is strictly unilateral and concentrated round the eye. Typically it is accompanied by a number of autonomic signs. Ergotamine, oxygen and sumatriptan are effective for attacks. Prophylactic agents used include ergotamine, lithium and corticosteroids. Chronic paroxysmal hemicrania. A rare condition, predominating in women. Typical very frequent, short-lived attacks of pain occur of a type similar to cluster headache. Autonomic symptoms are common. Indomethacin, in a dose of approximately 150 mg/day, aborts the attacks within 48 hours. In most patients, the attacks become chronic. Idiopathic stabbing headache. Defined as recurrent, very brief, stabbing pains, usually confined to the head, occurring singly or in runs. They tend to occur in subjects with migraine. They respond to regular indomethacin therapy. Differential diagnosis. Cranial arteritis, also known as temporal or giant cell arteritis. This is a granulomatous inflammation of the medium and large-sized arteries of the cranium and elsewhere. Within the cranium, the arteritis is confined to those arteries possessing an internal clastic lamina. The loss of vision is the consequence of involvement of the posterior ciliary artery, leading to anterior ischemic optic neuropathy. Epidemiology: the condition is rare under the age of 50 years. The mean age at diagnosis is approximately 70 years. The condition is slightly more common in women and almost confined to Caucasians. Cranial arteritis. Superficial temporal artery biopsy showing intimal thickening and medial damage and giant cells with inflammatory cell infiltration in the internal elastic lamina. Symptoms of cranial arteritis: headache, usually localized, pain on chewing, jaw claudication, general malaise, proximal muscle stiffness and pain, visual loss. Clinical manifestation symptoms: headache occurs in the vast majority of patients. It particularly localizes to one or other temple but may be more generalized. Constant, boring, intense pain, exacerbated by contact, brushing the hair and also by exposure to cold. Pain on chewing occurs. Jaw claudication. Many patients feel generally unwell, with malaise, anorexia, weight loss and night sweats. Stiffness and pain in the shoulder and pelvic girdle muscles. Polymyalgia rheumatica may antedate or coincide with the headache or appear as a separate entity. Before persistent visual loss there may be amaurosis fugax. Clinical manifestations, signs: the scalp vessels are tender and thickened. Pulsation is reduced more often than it is absent. Scalp necrosis is rare. The optic disc is swollen and later pale. Ophthalmoplegia is sometimes seen either as a sixth nerve or a pupil sparing, third nerve palsy. Stroke incidence is low. Rarely, involvement of the aortic arch or of the mesenteric or limb vessels is symptomatic. Cranial arteritis. Thickened superficial temporal artery. Cranial arteritis. Fundus photograph showing ischemic optic neuropathy in the acute phase. Therapy. Corticosteroid therapy should be started immediately while biopsy is being arranged. There are advocates of both high-dose and low-dose regimes initially, for example 60 mg or 20 mg daily of prednisolone. Eventually, patients are maintained on 7.5 to 10 mg daily. The condition tends to resolve after 12 to 24 months, when treatment can be withdrawn, though some authorities advocate long-term therapy. Cranial arteritis. Cranial arteritis is an important condition to exclude in an elderly patient with a newly acquired headache. The affected arteries are tender but usually still pulsatile. The erythrocyte sedimentation rate is usually markedly elevated but rarely normal. Corticosteroids are the drugs of choice. Meige syndrome. This condition is the result of dystonic stimulation mediated through the facial nerve. Occur in middle-aged or elderly individuals. The signs of orofacial mandibular dystonia and blepharospasm are characteristic. The changes, which resemble tardive dyskinesia, are not induced by neuroleptic drugs and are unlike the open-mouth dystonia of Bruegel syndrome. Lower pontine lesions can be identified in some cases. There may be temporary improvement with haloperidol, tetrabenazine, or intravenous cogentin. Botulinum toxin injection into the affected facial muscles is the treatment of choice. Temporomandibular joint dysfunction. Degenerative changes in the temporomandibular joint are associated with pain in the jaw, sometimes referred to the ear or temple. The pain is exacerbated by chewing. Pain in a similar distribution, without evidence of joint derangement. Pain has been attributed to abnormal activity of the jaw muscles, either triggered by malocclusion of the jaw or the result of excessive jaw contraction in an anxious individual. Treatment is symptomatic.